So again, thank you so much for the opportunity. This topic is definitely one that's near and dear to my heart, both professionally and personally. I will discuss later on in this talk a project, a quality improvement project that we have done in my institution in order to improve specific outcomes for the ELBW infant. From a personal perspective, I had my own ELBW infant about 17 years ago, and she is now a teenager. So this is born out of a lot of experience, both professionally and personally. What we're going to do is we're going to get started, and I'm just going to outline some principles of management for the care of infants born less than 29 weeks and or 1,000 grams. We call them tiny babies here in our unit, and we call them tiny babies to distinguish them from the other smaller preterm infants that we have. The photos that you'll see have been shared with permission from a little guy that we had 5 years ago. In fact, tomorrow's his 5th birthday. And he was with us for a very long journey, and unfortunately he experienced a lot of the complications that these infants can have. The quality improvement project that I will discuss was definitely born out of his experience and the experience of so many others like him that are born in our facility. We're going to cover several topics within this broad scope. We're going to talk about the golden hour. We're going to talk about the first 72 hours, the first 2 to 4 weeks, and then the more chronic care of the ELBW infant. As you know, this is a journey for these infants. It starts way before birth, and it definitely continues after their hospital stay. Before we get to the golden hour, let's talk about before birth. What we need to know as neonatologists and attending physicians at the birth of these babies is really the very specific nature of the antenatal care of the mother. We need to know, what are these dates based on? A lot of these infants are born around the threshold of viability that is very particular to each country that we represent. What is the accuracy of those dates and the precision with which we measure them? Is it based on an early ultrasound? Is it based on a later ultrasound? Or are they based on the last menstrual period? This is very, very important, especially in the 22, 23, and 24 week gestational age categories. We also like to know, in terms of prognostication, the growth status of these babies as fetuses. Is this a baby who's small for gestational age or even IUGR? And are there Doppler abnormalities on the ultrasound that have been identified that may put certain infants into different risk categories? Are there infectious risks? Certainly, we all know that the baby whose mom has had ruptured membranes from 16, 19, 20 weeks puts them in a different risk category for various complications moving forward. In addition, what is the health of the mother? Have there been pregnancy-related complications such as PIH or gestational diabetes? And is the mom a generally well and healthy individual prior to pregnancy? We want to be involved and inform care prior to birth. The use of antenatal steroids, as Dr. Panza has mentioned, and as we all know, has really revolutionized survival and morbidity amongst these babies. We need to know when steroids were given, if they were given within 7 days of birth, was it a full or partial course? We also need to know if mom received latency antibiotics such as ampicillin, in our facility, ampicillin and erythromycin, or if she has received penicillin during the labor. We also we use magnesium sulfate infusions prior to birth for the for preventative neurodevelopmental protection. So I think those are all aspects, and just a few of the aspects that we really need to know prior to the delivery of these infants. We prefer to have a collaborative relationship with our maternal fetal medicine colleagues and our obstetrical colleagues well before birth. Multidisciplinary discussions, including the parents and their education, is key to starting the relationship and the chronic relationship that we're going to have with these families throughout the ELBW infant stay. We feel that sets the scene for having good parental involvement and presence during the long journey that these infants face. So we're going to switch now for a minute to the golden hour. So the golden hour is a concept that was really born out of the adult medicine side of things for post-stroke, post-MI care. But this concept is quickly expanded to many different areas of medical care. And it was recently, in approximately 2015, that the concept started beginning to be discussed for the care of the ELBW infant. That golden hour that starts right from the minute the baby is delivered from the mom and hopefully spans the stabilization time for these infants became a focus of care for a lot of institutions. As you can imagine, and as we experience in our facility, there are multiple challenges and multiple barriers to establishing the golden hour. The concept of the golden hour is that the baby would be fully stabilized, lines inserted, vent settings set, surfactant administered, and x-rays taken by 1 hour of age. And that for us in our institution has been very difficult because we have quite a geographic distance between our birthing unit and our Nicu. The concepts that have been discussed in golden hour have been environmental control, so definitively the correct temperature. We know that hypothermia for ELBW infants increases mortality and increases morbidity. So having correct temperature in the room and having correct temperature in the operating theaters, if the baby's being born by cesarean section, the use of warming mattresses, the use of overbed warmers, the use of warm towels are all extremely important to maintain normothermia for these infants. Other concepts of the environment include having a quiet environment and meticulous volume control. We know that when you step into a lot of NICUs, the thing that is the most noticeable right from the start is the noise level, especially if we're dealing with units that have one large open room with multiple babies. So getting control over the volumes, early silencing of alarms, keeping voices low is very important. In preparation for intubation, should the baby need intubation, if the institution has a policy of pre-medication for early intubation, having those ready and set out for babies, having the lines set up in the sterile trays, the sterile gloves, and the hand washing availability set up right before the baby's born, and a device to deliver Cpap, as we know that early PEEP for infants improves their respiratory management. The thought is that depending on the environment is that the infant would be fully stabilized with lines and tubes inserted and then would be shifted to the NICU. We can't do that in our environment because we don't have enough space over in our ORs or in our delivery suites that we can do that. So we have to stabilize, bring to our unit, do all the procedures, which is why the golden hour for us is still being worked on and expanded. Some institutions have been very successful at establishing the golden hour. After the golden hour, the first few days after birth are critical. It's been shown in the medical literature, both in adult medicine as well in pediatrics, that any standardization of care improves the outcome of patients, regardless of what is actually contained in that care strategy or care package. I think the concept is when you standardize care for a particular disease entity, state of being, or wellness, it raises awareness of the treating people and the healthcare providers around that patient. And that patient, just by definition, gets better care. Because of this standardization of care and the combination of quality improvement projects, these are both initiatives that can be very easily performed in various aspects and angles of the care of the ELBW, whether it's looking to focus on normothermia and thermal control, whether it's looking at ventilation parameters and settings and rates of reintubation, or how duration of ventilation. These are very easy, simplistic initiatives that can be done to improve outcomes in real time. And I think that's the beauty of doing quality improvement. So why do we do this? Well, it seems very simple, and yet it's so complex. We want to improve outcomes for these babies. As Dr. Panza mentioned, the long-term rates of neurodevelopmental disabilities or differences, respiratory morbidities, and even illnesses into adulthood. This is why we need to do this. And so when we started looking at our facility and our quality improvement initiative for the care of the ELBW or the tiny baby, we looked at 4 different centers, 5 actually. We looked at the Iowa experience. Dr. Jonathan Klein and his colleagues in Iowa have published the best outcomes for infants at 22 and 23 weeks. I've spoken extensively with Dr. Klein and listened to his talks, and they definitely have a massive bundle of care that they put into place for the 22, 23, and 24 week infants. And as such, they've raised the survival of these infants to well over 50%. If you listen to the literature that comes out of Japan, for example, they have a number of extremely small babies and at very low gestational ages. And they have a specific bundle of care that they apply to these infants as well. Berlin and Sweden are the other 2 major centers in Europe that have incredible outcomes for these tiny babies. And not only do they have incredible outcomes for the tiny babies, but they've got good long-term outcomes for the tiny babies that survive as well. And when you look at all of their strategies, they have a lot of commonalities. Thermal care, ventilation guidelines, no fluid boluses for hypotension, minute attention to fluid balance, and the use of probiotics. And those are all common with some subtleties, site-specific subtleties that they apply to the care of the tiny baby. In Canada, one of our centers, Sunnybrook in Toronto, they also have a small baby care strategy, and they did improve their survival without morbidity from 28 to 35%. That seems somewhat modest. However, if you look at what those morbidities are, we're talking about BPD, IVH, and ROP, which have significant repercussions to infants moving forward. And indeed, the Sentinel paper came from Morris in 2015, where they looked at a care package for small infants, and they found they reduced chronic lung disease, nosocomial infection, and discharge with growth restriction. They also looked at resource utilization, which we haven't looked at here at our center, but that could be another focus of any of these strategies. So how do you come up with these strategies? Well, when we were proposing to look at standardizing the care of the tiny baby, we really wanted to develop evidence-based protocols. And we looked, as I mentioned, from the centers of excellence around the world that were publishing extremely good outcomes for the little ones. And we also wanted to go to the literature. Because if you ever examine the evidence-based protocols from any of these centers, as I mentioned before, there are going to be site-specific differences that are really just born out of their facility, their environment, what they have found works for them. We then thought we wanted to come up with a number of checklists. So let's put something into place and let's audit it. Can we adhere to checklists? Can we get the lines in a certain amount of time? How about the x-ray? That's usually a limiting factor for us. Did the lab come on time? When did we get those first lab work done? How about pharmacy? Can we get caffeine into these babies in an early manner, and these sorts of things? So some of these strategies are going to have to be tailored to the facility and the environment that we all work in. We wanted to choose outcome measures that we were noticing a rise in. And those for us were chronic lung disease, retinopathy of prematurity, and late onset sepsis. We knew that our rates of severe intraventricular hemorrhage or periventricular leukomalacia were quite low from a national perspective. And we knew that our mortality rates were quite low as well across the country. We really wanted to see if we could make a difference in chronic lung disease and retinopathy. So there are certain essential elements, and this is my little friend that was on the first slide as he's getting a little bit bigger with his family doing some hand hugs. So there were essential elements that came up when we started doing this. We wanted family and optimal delivery conditions. So we wanted family involvement right from the get-go. COVID derailed that a lot. We're very good at getting dads to come into the resuscitation room or to come to the cot side when we're doing the active resuscitation. COVID, for a time there, we had mothers delivering without support people. So that's been a little bit difficult. But however, we're now back on reintegrating families into that initial management. The golden hour, as I mentioned, for us is very tricky. And we've started with the first 72 hours of care rather than focus on the golden hour for our environment because there's a lot of barriers to that. We really wanted to focus on mother's own milk or donor human milk and the provision of that milk in the first 24 hours of life. We wanted to revisit our strategies to prevent nosocomial infection with respect to how long to leave umbilical lines in, when is the appropriate time to insert PICC lines, and minimizing peripheral IV attempts. We wanted to maximize compliance with O2 saturation limits and targets. We wanted to ensure that we were doing evidence-based lung protective strategies. We wanted to ensure a developmentally supportive, positive infant interaction and care. And again, integrate the family into the daily care of our infants. So how did we do that? Well, we start with the antenatal consult and tours of the units. We spend a lot of time discussing with families the trajectory of the infant through the what can be a very long stay in the NICU. And we ensure that the parents have seen our environment prior to birth. To encourage mom's own milk and donor human milk, we ensure that we have colostrum kits that are provided to the mom even prior to delivery, that she can collect in tiny little micro syringes everything that she can express. We use oral immune therapy even when babies are NPO, using those first drops of colostrum between the gum and the cheek. We have set a goal to initiate feeds on day of life number 1, and we will use donor EBM in the first 6 hours for feeds if mom does not have any milk or colostrum. We have regular hand hygiene audits that are random and nobody knows they're occurring, so we can ensure that our compliance with hand hygiene is high. We have central line policies that are revisited and revised every year. We try to keep the intubation and re-intubation material clean. Oftentimes, you'll go to a delivery, you'll get your equipment ready, and the ET tube or the laryngoscope is lying open in the bed of the baby, which we don't do anymore. Our oxygen saturation limits and targets have been very tricky. As I said, we're trying to address our rising rates of ROP and BPD. So we do use 88 to 92 with the alarm limit set at 85 to 95. We envision potentially, as the babies get older, targeting saturations based on the ophthalmological exam and findings of how mature the retinas are, but we haven't gotten that far yet. An informal audit of our babies showed a frequent incidence of monitors where the high sat alarm had actually been turned off. So we do feel as though we've tightened that up quite a bit so that our babies are not sitting between 95 and 100%. We struggled a little bit when we started talking about lung protective strategies for the intubated patient. However, we settled on continuing to use volume-targeted ventilation as a primary mode of respiratory support, with caveats for using jet ventilation if there'd been prolonged rupture of membranes, chorioamnionitis, or early severe cystic PIE or BPD. We start resuscitation of these tiny ones with the FiO2 set at 30%, and we go to a Cpap of 8 and up to 12 before, in the resus room before intubating. We give routine caffeine for these little tiny babies, and we will use INO for the early oxygenation failure. We use postnatal dexamethasone according to the DART regime at greater than 10 days of age, not before, but we do not use dexamethasone technically as a rescue therapy. We have on occasion used nebulized budesonide, but for us, we feel that the evidence doesn't fully support that. And we use transcutaneous PCO2 monitors in all cases if the skin maturity allows. And sometimes that is our rate limiting step. So developmentally supportive and positive infant interactions, as I mentioned before, prompt silencing of all alarms. We keep the lights off or the eyes covered on a diurnal basis. We do minimal handling according to baby's cues, and we keep the head in the midline for 72 hours at all times for all procedures to encourage neuroprotection. So what did we actually show? Well, after doing all of that preamble and all of that work and all of the conversations with other centers, and I visited other centers to actually get to have an experience and get the flavor of what they were doing, we ended up being the first tiny baby initiative in our province, and we're definitely one of the first in our country. We have a multidisciplinary tiny baby committee that is comprised of physicians, respiratory therapists, nurses, occupational therapists, physiotherapists, speech and language pathologists, our pharmacists, a parent of a preterm infant, and social work. And I have to admit, the enthusiasm and the dedication of my committee is absolutely incredible. We have a 32-bed level 3 nursery, and our health region is called Fraser Health. We're just outside of Vancouver. In 2019, we had 573 admissions to our level 3 Nicu, including 130 infants under 33 weeks and 40 under 29 weeks gestational age. I can tell you that in 2020, while a lot of centers were experiencing a decreased rate of preterm birth, we were actually experiencing an increased rate of preterm birth, to the point where we were almost overwhelmed by how many infants tiny babies we actually had. As we saw the numbers of small babies rising, we also saw the incidence of chronic lung disease and ROP requiring treatment rising as well. So we did get together this quality improvement initiative to address those outcomes. And the definitions that we use are used by our Canadian Neonatal Network database, which is oxygen requirement at 36 weeks gestational age, and retinopathy of prematurity defined as stage 2 or higher or needing treatment. We started with standardized admission order sets for infants less than 28 weeks and or less than 1,000 grams. So sometimes we get more mature infants who are small. So we do have quite a lot of small for gestational age infants. We have as I mentioned, specialized supplemental policies as well. We developed an OIT policy, an oral care policy, a fluid management policy, neuroprotection, ventilator-associated pneumonia prevention, and oxygen saturation limits. It's incredible what can occur when you just start with one package, and all of a sudden we have all of these spin-offs that just came because we heightened our awareness about the care of these infants. We collected the data after implementing this for 1 year, and we compared it to the previous year. So the cohort before the intervention was cohort 1, and the cohort after the intervention was cohort 2. And what we found actually was quite dramatic in terms of the outcomes that we chose to study. I'll discuss this slightly higher rate of death in just a moment, but for a second, to focus on both the BPD and ROP rates. We actually managed to reduce our BPD rate from 60% to approximately 46%, our ROP rates from 24 to 18%. And despite the fact that we have a baseline, very small incidence or low incidence of severe neurologic injury, we actually managed to reduce that as well, which was great. When we looked at death or BPD as a composite outcome, we had actually reduced that as well. So we were very encouraged by the outcomes that we chose to study. We needed to look a little bit closer into why the deaths had gone up. So when we actually looked, we had similar numbers of babies in each gestational age cohort. In 1 year, in cohort 1, we had 6 23-weekers, and in cohort 2, we had 5. Now, in cohort 2, unfortunately, we had the vast majority of those infants were twins. And unfortunately, we lost 2 sets of 23-week twins. And both of them, their mothers had had prolonged rupture of membranes from approximately 19 weeks. So we were gutted to see that we had lost those infants. But on further analysis, we did see that they had additional risk factors for mortality in the first 72 hours. When we excluded those infants, what we were very happy to see was that the survival was very high in all other gestational age strata across the 2 cohorts. So we had similar rates of survival, 24 weeks, 25 weeks, 26 weeks, 27 weeks. We have 97% survival in our tiny babies. Do we have to work harder at the 23-week infants? Absolutely. We need to go back to the drawing board and see what else we can do for those infants. But we were reassured that the overall mortality in the other gestational age ranges was still similar between the cohorts, while reducing BPD and ROP. So what has happened since then? So that cohort ended in October 2020. Well, what we've done, we're doing these PDSA cycles that you do in quality improvement, and we've gone back to the drawing board. So we've re-examined the literature on ventilation. We've re-examined the literature on feeds and gastrointestinal care. We now are using histograms, oxygen saturation histograms on our monitors. We've re-examined lab work and how frequently we do lab work and what lab work we do. We also decided we needed to develop a skincare policy. We had a number of 22 and 6 or 23 and 0 or 23 and 1 infants who ended up with significant skin issues. And really, we had not a whole lot of guidance out there in order to, is there anything prophylactically we can use? Is there anything that we can use as dressings? What do you do when you get skin breakdown? How does the humidity affect it? When should we be weaning our humidity? So we almost have version 1 of our skincare policy. The other thing is we recognize that our NICU has a very generic handout for parents when they arrive in the NICU. But we just didn't think it was fitting the bill for the parents of the tiny babies. We didn't feel that it gave an accurate reflection about what the journey was going to be like. And so we had our committee develop a small subcommittee to establish a wonderful parent handout that walks the parents through the environment, the personnel, and the trajectory, including complications for their babies. The other thing that we realized that we were missing, we don't have a specific neonatal follow-up clinic in our region. Our babies are seen at the Quaternary Center, which is BC Children's Hospital, and they are seen there for follow-up, but we were never getting any data back. So 2 things that came out of that is we now are having upper-level conversations with administration to develop a neonatal follow-up clinic for ourselves. The other is to access a neonatal follow-up database that exists out of BC Children's Hospital to get 18-month follow-up, both from a from a neurodevelopmental perspective. And we have a proposal into them to access the data for cohort 2 to see if BPD as we currently describe it, or ROP as we currently define it, if that actually translates into longer term issues for our patients. So now we're going to switch gears a little bit and just look at how we can monitor and treat babies in the first 2 to 4 weeks. We have a process of early diagnosis of patent ductus arteriosus in our institution with cardiology support. We do not do TN echoes or functional echoes ourselves as neonatologists in our unit. We are not a surgical center, our cardiovascular surgical center for ductuses. So we have a very low rate of surgical treatment of our ductus. And we use medical management pretty much 97% of the time. We do a lot of watchful waiting on these babies. And if we do treat medically, we treat with ibuprofen or Tylenol as our top 2 pharmacologic agents. We have individualized approaches to nutrition. So our babies initially are put on weight-based feeding plans, and our TPN is gradually weaned as the baby reaches full feeds. We use human milk fortifier. We don't use Prolacta or human-derived milk fortifier. We also use liquid protein to ensure good linear growth, especially between 2 and 4 weeks, but even onwards as the babies grow into more of a chronic nature. Our dietitians hand calculate all of the needs of our infants, including the vitamins and trace elements, to ensure that we give a cocktail that's very much individualized for each baby. We have early identification of metabolic bone disease with supplementation of calcium and phosphate as need be. We like to say that we avoid late onset sepsis. We do use PICC lines and umbilical lines. And however, despite having good policies and protocols, we do still have late onset sepsis on our radar as an issue that requires ongoing care and education. We are always looking at our respiratory care. We have a very high rate of early extubation, even in the tiny little ones. And we use NIAV or NIPPV as our primary mode of post-extubation respiratory management. We will then wean to Cpap, and then we will go to low flow nasal cannula if we need to for these babies. We have, as I mentioned before, we have developed a spin-off of this as being a full ventilator-associated pneumonia bundle of care for our intubated patients, which addresses patient positioning, ventilator positioning, how frequent we suction, how frequently we change the circuit, oral care, hand hygiene, and all of the rest of it. I think there's probably about 15 bullet points on our VAP prevention bundle, and that gets posted at the bedside of every intubated infant. And we do use caffeine on an ongoing basis until approximately 34 weeks, unless the infant is clearly doing well and not having any apneas, bradyes, or DSATs of prematurity earlier than 34 weeks. What we've also done, this is my little friend, same little guy who's turning 5 tomorrow. So we have chronic or BPD order sets. When a baby turns 36 weeks and is officially, by our definition, declared to have BPD, we use echocardiography to rule out any pulmonary hypertensive component. We do weekly gases and chest x-rays. We do very slow weaning of respiratory support so that we can continue to support the baby nutritionally and from a growth perspective. We use low flow, heated humidified, low flow nasal cannula. We adjust the oxygen saturation goals up to greater than 94% at 36 weeks. We ensure that the baby doesn't have sick euthyroid by doing TSH and free T4s, and we avoid anemia and make sure that we're giving adequate iron substrates for infants to recover from anemia of prematurity. In consideration for home, if we have a baby who has reached 42 weeks corrected gestational age and are still requiring NG feeds and or oxygen, then we will train the parents to do home NG feeds, and we will send the baby home on home oxygen. However, having said that, despite our high numbers of small babies, it's very rare that we have to do that. And it's very rare that we send babies home on home oxygen here in our facility. We have a wonderful group of community pediatricians who take care of our babies once they go home, and they're very well versed in the care of the ex-preterm infant. So just to conclude and give lots of time for questions, we all know that the care of the Elbw or tiny baby is complex, but we can improve it with standardization of care. The team that we work with is crucial to the care of these babies, and the team is inclusive of all healthcare disciplines, and most importantly, the parents. And I thank you for that. And I will, I'd love to take questions.
Thank you very much, Dr. Sherlock, for this wonderful presentation and for sharing your experience across the big pond. And thank you very much. I will move forward to the questions because we have quite much. So the first is mother with preterm prolonged rupture of membrane with no preterm labor. What is the evidence base for how long the pregnancy can be prolonged, assuming there is no maternal indication for labor or normal Dopplers?
Thank you for that question. It's such a good one. In our facility, we tend to go until 32 weeks if all is well. We also have the benefit of having a wonderful obstetrical at-home program. So mothers like this are visited by antepartum nurses, and so they are monitored on a regular basis, both with their OBs and from the antepartum home care program. So they tend to come in for induction at 32 weeks.
Thank you. Could you explain no fluid bolus for hypotension as a strategy to improve outcomes?
Absolutely. So we know from the literature, and this is from the literature in the early 2000s, that the more fluid boluses little ones get, the more likely they are to develop bronchopulmonary dysplasia, even when corrected for a lot of different factors. What we know about the preterm infant is that they're not intravascularly volume depleted unless you've had umbilical cord rupture, bleeding, abruption, like you think that this baby has lost blood in the process of birth. So the concept of giving fluid boluses to an infant that's not in hypovolemic shock doesn't really make a lot of intuitive physiologic sense. And certainly when you listen to the Japanese and the guys from Berlin speak, they have banned fluid boluses unless those particular things, hypovolemic shock. They're more inclined to start inotropic support before they would give a fluid bolus, unless they have a good reason to say that the baby's in hypovolemic shock.
Clear. Thank you. What is meant by colostrum kit? Are you able to encourage express milk on day one?
Yes, thank you for that. We are again very fortunate to have lactation consultants that work both in the Nicu and over on the birthing unit. The colostrum kit is a one package thing that has super tiny little micro collection tubes and tiny little syringes. So, and a pamphlet on how to actually extract maximum amounts of colostrum. So every preterm mother gets a colostrum kit and a visit from the lactation consultant right after birth, and they are encouraged to, suck up these tiny little drips of colostrum off the nipple and put them in these micro collection tubes. Because they're specialized tubes, we don't lose anything. And so we're able to use that for OIT, oral immune therapy, to start with. And then, yes, we are able to encourage expressed milk on day of life number 1.
Also, what is included in lung protection strategy other than dexamethasone?
So our lung protection strategy includes use of volume targeted ventilation to start with, surfactant therapy, obviously, and antenatal steroids if we can possibly get them in there. We definitely use low lung volumes. We use PEEP in a very, I think, in a fairly aggressive manner. And we're always targeting the lowest possible settings on any whichever ventilator we use. If we have a baby who looks like they need more than 5.5 mils per kilo tidal volume on volume targeted ventilation, we will go to jet ventilation in order to give a higher mean airway pressure without having to provide the barotrauma and volutrauma.
Thank you. As per Cochrane, there is no benefits for early INO use in preterms. Could you please share your experience?
Yes, thank you for that. Absolutely. This is like, as an evidence-based medicine practitioner, this is a very tricky one. We use it as rescue. Particularly in an infant whose mom had PPROM. So say, delivery at 23 weeks, ruptured membranes from 18 weeks, and pulmonary hypoplasia. And we struggle with the literature for sure, because I fully agree with you that Cochrane shows no difference. So it's used as rescue. If you're on 100% oxygen, you're on the jet ventilator, and you're just not getting anywhere else, and you have a single organ disease, so lungs are the only thing, you don't have a severe neurologic injury or anything at that time, we will use INO. And we recognize that it's rescue therapy. It's essentially experimental therapy for these babies, and we will use it in that fashion.
Have you studied outcomes in those babies where you have used INO?
So now this is anecdotal because I don't have the data in front of me, and we don't use it very often because it is a rescue therapy. But I can say we've used it a handful of times in the last year, and we haven't lost one of those babies yet. I do not know about their long-term outcomes, but nor have we had severe IVH in those babies.
And what is the dose and duration of INO you use in such babies?
So we start at 20 parts per million, just to see like if there's going to be any effect, we're going to get the effect. If we get an effect, we will titrate down to 10, knowing that the literature says that there's likely not a big difference between 10 and 20. And then we just titrate to effect as the baby gets better.
Okay, thank you.
You're welcome.
Also, do you use erythropoietin for anemia of prematurity in extremely low birth weight infants?
We don't, actually. The only time we would ever use EPO is in babies whose parents have a religious objection to transfusion. So yeah, I haven't used erythropoietin in a really long time.
Do you recommend dexamethasone with the DART regimen, even for babies on non-invasive respiratory support beyond day 10?
No, we don't. These are only for intubated babies who it looks like you're not making any progress, still in quite a bit of oxygen despite adequate surfactant and ventilation, but definitely invasively ventilated.
If if you give DART regimen in such babies and still they remain intubated, what do you do next?
Wait,
So you don't repeat.
nutrition. We don't right off the bat because, so this is how we approach DART. If I start dexamethasone, we know the maximum dose is in the first 3 to 4 days. If I don't get a response in 3 to 4 days, I stop it because the baby's not going to respond as we start de-escalating the dose. And I don't want to give if I don't have to, I'm not going to give the baby extra dexamethasone just in case. You know, we all know the literature related to dexamethasone. If we categorize the baby as a DART responder, we'll carry on the full DART regime. So that's not to say the baby won't get dexamethasone again, because in another couple of weeks, we might be looking at using it as a rescue situation. If the patient is still intubated, we're not making any headway, and despite adequate nutrition, growth, fluid management, and all the rest of it, we're not getting anywhere.
How do you define a positive response in babies receiving DART?
So what we usually look for is the ability to wean very quickly on our pressures and our FiO2.
Apart from dexamethasone, is there any other therapy which you use for such babies who remain intubated beyond 10 days of life? Like
No.
furosemide and all, short course furosemide?
We definitely do not. We do not use diuretics. We never use diuretics, to be honest. I can honestly say that we never use diuretics.
That's good.
Yeah.
Over to you, Dr. Rafael.
How do you keep consistently the sound levels below the permissible limits in Elbw Nicu? So
we're lucky that we have, our nursery's 5 years old and we have single room NICUs. So we're very, very lucky. The alarms are not, they ring outside the room. So we've got central terminals just outside the room. And so the alarms don't go off in the room, they go off outside the room, and they can be silenced both in the room and outside the room. So we try that way. I mean, honestly, we all speak loudly and we all get excited, and it's a conscious effort and a constant effort to, you know, get everybody to keep the noise levels down. But generally speaking, if we're only handling every 6 hours, the baby's in the room, the doors are closed, and everybody else is outside the room. So we're able to do a good job. It's not perfect, but we're able to do a good job on keeping the noise levels down.
Great. Do you use oxygen by hood in these newborns? And do you actively humidify the low flow oxygen also?
No, so we don't use oxygen by hood. We always use cannula, and we have OptiFlow, so it's heated and humidified by nasal cannula.
What should be included in the skin care bundle?
Well, that's a great question. Thank you for that. We have extensively searched the literature to see if we should be using an emollient, which before, you know, back when I was a resident, we used Aquaphor. We don't use Aquaphor. So we now use skincare bundles should include your approach to humidity, okay, and temperature control. We use 100% humidity, and we use in the incubator, we use a plastic tent over the baby. So because you're opening the portholes and all the humidity is leaving. So we use 100% humidity for the first 72 hours, and then we wean. So humidity should be included. Your own institution's approach to emollients. So are you going to apply skincare products in a preventative fashion to your babies? Because we use 100% humidity, we do not put lotions on the skin. It should be, what do you use as a mattress how do you support the baby in terms of pressure points and pressure sores? What tapes do you use on the face for the ventilation? Are you able to use transcutaneous? So everything that gets stuck to the baby should be part of your skincare bundle. What to do when you have areas of breakdown? We use a dressing called Mepitil that you just put on the skin and you leave it if the area is open. So emollients, humidity, what fasteners you use, and what to do in cases of skin breakdown. Those are all the elements that you should include for a skincare bundle.
Any experience with use of oils, vegetable oils in such babies?
No, and I think the oils we get concerned about only, like, first of all, from an infection perspective, if you have breakdown, that might be a good medium for bacteria to grow. The other one is if you have to use phototherapy, I'm not 100% certain how that interaction might go. To be honest, I haven't looked into oils, so I don't know that much about them, but those are the two theoretical concerns, I think.
Let's move on. Do you use probiotics as a primordial prevention for NEC in Elbw neonates? And if so, which probiotics?
So we don't, because we looked at the literature, including, well, there was just a recent meta-analysis, and to our minds, the actual literature has never supported the use in the ELBW infant. There just wasn't enough robust, methodologically sound RCTs looking at that very narrow population. So we do not use probiotics. We had been using probiotics in the greater than a kilo baby, but with the recent meta-analysis, we just decided that the evidence isn't there to support its use, and so we do not use them.
Even for VLBW babies, or you don't use only for ELBW babies?
No.
No probiotic use in the unit?
That's right, because even when we initially started using probiotics, when you actually tease out how many tiny babies had actually been treated with probiotics in those studies, very, very small numbers.
Totally.
So we didn't think it supported its use. And we also, again, fortunate to have a very low rate of necrotizing enterocolitis for whatever reason. I don't know why, it's just, we don't have it.
Do you use prophylactic antifungals in ELBW babies?
No, again, as a site-specific variation, some of I know Iowa uses prophylactic fluconazole. We don't, because, knock on wood, we've never had a culture positive fungal sepsis in our unit. We're just really lucky that way.
Thank you.
Also, we have a lot of questions. What is the
Okay, good. I love it.
What is the unity policy for vaccination in ELBW babies?
So we start our immunizations at 60 days from birth. So we do 2, 4, and 6 months. That's the DP, TP, and Hib, Pneumovax, and meningococcal. And we repeat that at 4 months and at 6 months. So we use their birth date.
Okay. Do you prefer to perform the immunization in the unit, even for the repeated doses?
Yeah, if they're still here, for sure. And if they're coming, we're kind of funny that way. If they're coming up on discharge date and maybe 2 days later, they're scheduled for an immunization, we kind of hold them if we can, if we've got capacity, give the immunization, wait 48 hours, and then send them home.
Okay.
Yeah.
The next question is regarding respiratory support. What is your primary respiratory support for ELBW babies? Do you put all babies on Cpap, or you electively intubate?
So we don't electively intubate. We definitely provide Cpap in the delivery room. And then we assess. The vast majority of these infants, whether you're born here, Iowa, Berlin, Japan, doesn't matter. They need intubating. So we don't mess around, but we will provide Cpap initially. We'll put the tube down. We use volume targeted ventilation. So we use assist control with volume guarantee.
For all babies?
Does providing Okay, sorry.
And
Yeah,
you don't
all
shift.
babies.
You don't shift from assist control to PSV. That is the single mode you will continue to use till baby is ventilated.
Yep. Unless they have to escalate to the jet.
What are the settings for CPAP? You start with 8 and go up to 12.
When we are in the DR, in the delivery room, we use 5, and I'll go up to 6 if the baby's in quite a bit of oxygen. But we will use, on our ventilator, we will use PEEP up to 8.
Awesome.
The
And
CPAP in a chronic fashion, we will use up to 12.
okay, so you use bubble CPAP or you use ventilator CPAP?
We have, what do we have? We have biphasic machines. We've got Cpap machines.
Okay, so you use DOPAP?
Yes.
Okay. And when do you consider baby has failed non-invasive respiratory support?
If the FiO2 gets to 30%, that's a criteria for surfactant right there. If the work of breathing is, moderate to severe, we don't wait. We know that baby's going to tire out. We know that the height of RDS is going to be somewhere between 24 and 36 hours. So if we have a baby who's working hard, who's escalating on CPAP or NIPPV, which we also use as well, we'll go from CPAP to NIPPV to intubation if we have to. The little ones, of course, we're intubating in the delivery room. We'll give CPAP just as we get ourselves sorted, put the tube down, and put the baby on ACVG.
Over to you, Dr.
What is a preventive measure of BPD and how to suspect BPD? Well, that's a $1 billion question, isn't it? Let's see. No preterm delivery. That would be great. Gentle ventilation. So the open lung concept. So only using what you need to use, but no less, right? You don't want atelectotrauma, you don't want barotrauma, you don't want volutrauma. So gentle ventilation to avoid changes to the lung architecture, ventilator-induced lung injury, early extubation, use of PEEP, good nutrition. This is what I say to the parents all the time. The only proven treatment for BPD, there's 2: time and adequate nutrition. They have to grow. They just have to grow. You have to support them as they need to be supported until they can grow. And if you can buy them time, they will recover. But oftentimes that's the hard part. So gentle ventilation, adequate nutrition, judicious use of fluids, and tiding them over until they can grow and develop their lungs.
Do you use azithromycin in babies with BPD?
No, we don't.
And do you use IVIG in neonatal sepsis as rescue therapy?
No, we don't.
Could you please share your feeding protocol in 23 to 25 weekers? What is the neck prevalence you said, and what strategies have helped the most?
So our neck prevalence is about maximum over the last 4 years has been 3%, but there have been years where we're at 0. We really just don't have necrotizing enterocolitis. Again, knock on wood. We use weight-based feeding plans, and for the tiny little ones, that means they'd start off, they'd have 3 days of what you could consider trophic feeds. Okay, so they'll get they start at 15 mils per kilo per day for 2 days, then they go up to 30 mils per kilo for 2 days, and then they go up to 60, 90, 120 mils per kilo per day. So we gradually get them up to, they usually reach full feeds somewhere, depending on the weight, between 7 and 10 days. And again, our neck prevalence is low, and that we literally have no other strategies other than OIT, early provision of mom's milk or donor human milk.
Thank you. Do you practice kangaroo mother care in sick extreme and in stable preterm babies?
Definitely. We encourage skin-to-skin care for all of our babies. With the tiny little ones, again, you have to wait until a little bit of skin maturity. You have to wait we have a 72-hour neuroprotection plan. So you don't take them out in the first 72 hours for skin to skin. But after that, if they are stable, even if they're on jet ventilation, we will get, and even if they have umbilical lines, we will get them out for skin to skin.
And what is your opinion about umbilical cord milking in ELBW? What is the cord management protocol in your unit?
So we do delayed cord clamping. So we're there at the time of birth, and we'll, kind of stick our heads in and look at the baby as the baby's on mom's tummy, or if the baby's being delivered by C-section, we'll be communicating with the obstetrician. Does the baby seem vigorous? Is there some movement? How's the tone? If that's all good, we'll do delayed cord clamping for a minute in these tiny babies, unless there's a risk to mom or a risk to baby. We don't do cord milking because, if I remember correctly, the last report of cord milking showed that there was an increase in IVH in these babies. I think. It's been a while since I've looked at it.
That's right.
But is that right? Thank you. I'm so tired, honestly. So we don't do cord milking. We do cord clamping, and that is working beautifully. So yeah, that's what we do.
Okay, thank you again. And covering the eyes on the diurnal basis, how is it being done?
So we've got, first of all, we've got light control in our rooms. It's a pretty fancy unit, I have to say. I'm very, very lucky to work here. So we've got really good lighting systems. We also use incubator covers. Worst case scenario, if we have to have a baby fully exposed, we've got some little shades that we put on for the baby. We've got lots of different ways of doing it.
And how much higher PCO2 you permit in growing preterms?
So growing preterm. So initially I set my blood gas parameters to keep the PCO2 between 45 and 60. As they get older, we all know these babies, they're 33 weeks corrected, they're puffing away on NIPPV or Cpap. If they're stable and their oxygen's okay and they seem comfortable, we might leave them alone if they reach 65 without touching the settings. I think one of the things that we do too much of, even in the acute stage, is micromanaging, and we're worse at it in the chronic. You want to get in there and you want to change something, you want to tweak something, you want to turn this knob or turn that knob. I think sometimes for the chronic babies, it's better to just go, okay, just step back. It's a moment in time. We all know that BPD has fluctuating VQ mismatch. Just stop touching the baby and see what the baby does. So we try to not do overly frequent gases, because that's going to cause us to change something. So we'll let it go to 65 in a chronic baby.
And maybe last but not least, for sure, could you please share your high-risk babies follow-up protocol? So basically, what neuroassessment tools do you use?
So they are seen, as I mentioned, at the Regional Children's Hospital, so BC Children's Hospital, and they see, they're seen at 8 months, 4 months, 8 months, and 18 months. And what's wonderful, it's a wonderful clinic. It's a multidisciplinary clinic. They use the Bailey, the most recent version of the Bailey. They have an assessment by physio and OT, audiology, speech and language pathology, and then a doctor's visit as well. But it's usually the Bailey scales, and then they're if they have cerebral palsy, they're categorized with the GM-CSF. So that's kind of the tools that they use over there for our babies.
So today's last question is, do you use different saturation targets for different conditions in babies, or it is just 90 to 94?
Yeah, we don't. We use the same. I mean, obviously outside of a cardiac infant, or obviously like somebody, you know, a cyanotic heart lesion or a ductal dependent lesion, but we use 88 to 92 for our little ones. And we then we'll just upgrade it as the baby gets older. So we'll use 92 to 96 at 32 to 36 weeks. And then over 36 weeks, we use greater than 94.
Thank you so much. Despite a busy schedule, you made it on
I did.
time, and you took so many questions.
I love it.
Sorry for troubling you, and it was
At all.
lovely having you. Have cleared many of doubts of our participants. And thank you, Dr. Rafaela, for moderating the session.
Thank you.
It was indeed a great pleasure to have you both together. Thank you.
Thank you so much. It was a pleasure.
Same here. And please take adequate rest.
Thank
Thank you very
you.
much.
Have a good
Bye.
day. Bye.
See
Take
you
care.
next time. Bye.
Thank you.